All right, good morning again, everybody. I'm Jeff Strawn from Cincinnati and University of Cincinnati, Cincinnati Children's Hospital. One of the things that we thought was important as we were discussing the pediatric anxiety disorders is the role of complicated anxiety disorders or a primary anxiety disorder with some specific comorbidity or in a unique population. And over the last 5 or 6 years, there's been accumulating evidence speaking to the treatments in these populations. So we've organized this section of the talk around anxiety disorders plus ADHD, wherein we now have 3 or 4 studies, as well as anxiety disorder plus major depressive disorder, wherein we're probably more at the expert opinion level of evidence, and then also looking at anxiety disorders in patients with comorbid bipolar disorder and in kids who have a family history of bipolar disorder, thus putting them at increased risk for mood disorders, including bipolar disorder. Then Dr. Conley will talk about the comorbidity of anxiety disorders plus pervasive developmental disorders, and also about comorbidity with substance abuse, which has very specific treatment implications. So looking first at the anxiety disorder comorbidity, again, I think we all in the room know as child and adolescent psychiatrists that a number of patients presenting to us with ADHD are going to have comorbid anxiety. And we need really look no farther than the MTA study, wherein about a third of those patients actually had anxiety disorders, the most common being generalized anxiety disorder, social phobia, and separation anxiety disorder. We have a series of studies which have actually looked at the moderating effect of anxiety on stimulant response in kids with ADHD, and also on the effects of comorbid anxiety on attentional processing in these kids. I wanted to emphasize just one, and I apologize for the red type. This is a study looking at about 60 kids who were prospectively treated with methylphenidate or placebo, using a crossover design. And what was observed was that methylphenidate response was inversely correlated with the reported level of anxiety. So more anxiety, less likely to response. Now, importantly, they recommended that anxiety be taken into account as one chooses treatment and monitors treatment. We have one of 2 studies that I'm going to talk about regarding a specific psychopharmacologic intervention in kids with the comorbidity of ADHD plus anxiety. And there are conflicting recommendations in the literature in terms of how this should be managed. The first study, looking at atomoxetine, is actually a placebo-controlled trial. They looked at the severity and burden of anxiety symptoms using the PARS, the Pediatric Anxiety Rating Scale. And these kids had ADHD plus one component or multiple components of the pediatric anxiety disorder triad that Dr. Connolly alluded to, the GAD, social phobia, or separation anxiety disorder. So very similar in terms of population, at least with regard to anxiety, as we've seen in most of the anxiety trials. Dosing was pretty standard with regard to what we're used to seeing clinically, at least in terms of the target dose. They may have gone up a bit faster than I know I typically do in the office. It was over 12 weeks, so relatively short for how we think of the latency of effect that emerges with atomoxetine. Looking first at the anxiety symptoms, so improvement in terms of mean PARS score, there was a statistically significant difference between atomoxetine and placebo, although it was not terribly impressive. The overall effect size was 0.5. Looking at the ADHD symptoms, although I've left the asterisks off this slide, there was significant improvement over the course of treatment. So here a study showing that atomoxetine may improve both anxiety as well as ADHD symptoms in kids with the comorbid condition. Side effects, not dissimilar from what we've come to expect clinically with atomoxetine. The only statistically significant difference was in terms of decreased appetite. I kind of expected a little bit more in terms of GI complaints, although that didn't tend to be the case. The next study I think is a very interesting one in that it looks at sequential treatment. And this is something that's important because this is often a recommendation in many of the guidelines, either in terms of treating ADHD first or in terms of treating the most impairing of the two conditions. And we actually had a discussion last night with Dr. Stock regarding a couple patients who had improved in terms of their anxiety after starting a psychostimulant. So this study looked at kids with ADHD plus anxiety. They were randomized to, or rather stabilized with a stimulant, in this case methylphenidate. And then those kids who continued to have residual symptoms were randomized to fluvoxamine or placebo. A couple things worth taking away from this, one being that a number of kids had improvement in their anxiety just with treating the ADHD. In terms of the number of completers, again, you see the numbers kind of decreasing here, but only about 20 folks completed. What was observed was that there was actually no difference between the fluvoxamine and the placebo groups in terms of anxiety symptoms. And we'll talk about this a little bit later as we try to put together some of these recommendations. And it didn't matter whether we were talking about anxiety symptoms, CGI, or whether we were talking about the ADHD symptoms. So in terms of recommendations, still I think in a situation wherein one disorder is more severe than the other, the recommendation would be to treat the most impairing disorder first. I would recommend avoiding a stimulant and SSRI being co-initiated. Possible benefits still, I think, of SSRIs in conjunction with stimulants, or rather following initiation of a stimulant, although that didn't seem to be borne out from the available study. Atomoxetine may improve both symptoms. And finally, guanfacine, although this is again at the expert opinion level of evidence, may be of some benefit in terms of some of the hyperactivity and impulsivity symptoms. There are some ongoing trials, and I also, as importantly, didn't mention my disclosure slide. I have received research support from ACAP for an evaluation of comorbid anxiety in kids with ADHD, and also from Shire and from Eli Lilly as well for psychopharmacologic studies of various meds and anxiety in kids. Looking at high-risk youth, these are kids with a family history of bipolar disorder who are presenting with anxiety symptoms. We recently performed a naturalistic study. This is Melissa Del Bello's study, on which I'm a sub-investigator, looking at kids presenting with anxiety or depressive symptoms, about half and half, who have at least one parent with bipolar disorder. And again, not to go through all of the data, but what you see here is that about half of the kids had poor responses to antidepressant medications. So looking at that in more detail, what you see here is a survival curve for time to discontinuation of the SSRI. What we see here is that in this population who may be more sensitive to the side effects of SSRI medications, that within about 3 weeks, most of these kids are needing to discontinue the medications. Looking here at basically a logistic regression of the probability of an antidepressant adverse event leading to discontinuation as a function of age, we see that there was a higher likelihood of adverse events leading to discontinuation in the younger kids versus the older kids. And I don't think that surprises us clinically based on our experience just in general of treating younger kids with SSRIs. All right, now looking at major depressive disorder, we know from the available literature that anxiety is a predictor of outcome, both in terms of CBT studies and in terms of psychopharmacologic studies. We know that there's a moderating effect in terms of the TASA study, the treatment of adolescent suicide attempters. And Dr. Connolly had alluded earlier to the fact that we do have some evidence for some SSRIs in both anxiety disorders and in major depressive disorders, specifically fluoxetine. Again, certainly there should be aggressive monitoring for suicidal ideation and consideration of anxiety-focused psychotherapies. This is a proposed algorithm looking at the treatment of the adolescent or child with anxiety and comorbid major depressive disorder. Again, recommending either of these three SSRIs for which we have good evidence in both conditions, or psychotherapy. Currently, evidence based on practice parameters from ACAP suggests evidence for IPTA, interpersonal therapy for adolescents, CBT, and also psychodynamic. Those practice parameters just published this year. And then again, in the case where you would have residual depressive symptoms, there is also evidence for switching to another SSRI in kids with depression. That would be primarily the Tordia study, and then there's also evidence from that open label study that Dr. Connolly talked about for residual anxiety symptoms, switching to another SSRI. In terms of anxiety in patients with bipolar disorder, we know that this is an important predictor of poorer outcome. This is a study of first episode mania, and what you see here is that the kids with anxiety disorders were markedly less likely to develop remission or to in fact respond to treatment. The key recommendation here is mood stabilization prior to any antidepressant treatment. And again, also recognizing the fact that SSRIs are going to tend to be more poorly tolerated in this population. So we can talk a little bit later about whether that brings in the need for earlier psychotherapy to address the anxiety symptoms or alternative psychopharmacologic interventions. So now I will turn over things to Dr. Conley.